Hello, everyone. We're going to be starting this webcast in about 4 minutes. We're getting some audio from one of the speakers and some typing. Okay, we're going to get started here today. I want to be mindful of everyone's time. So good afternoon, everyone, and welcome to today's webinar, Managing Benefits for Employees with Dermatological Conditions. I'm Stacey Worthy. I'm counsel to AIMED Alliance. I have my colleague, Mike Walsh here.
Hi, I'm Mike Walsh, Executive Director of the Dermacare Access Network.
So before we get started today, I just want to note that you can submit text questions to our speakers throughout the webinar. You can type your questions into the question pane of the control panel, which is located on the top right of your screen at any time. We'll answer those questions during the Q&A at the end.
So without further ado, I'd like to introduce our panel today. We are joined by Dr. Adam Friedman, who serves as Professor and Interim Chair of Dermatology at GW School of Medicine. He's also President of the Dermacare Access Network. We also have Chris Costello, who is co-founder and managing partner at CBG Benefits, a division of Risk Strategies. And finally, we have Catherine Theodore, who's a registered nurse and regional director of health strategies at United Healthcare. I'd like to thank each of you for being here today.
Good to be here.
Great to be here.
Thank you. So just quickly go over our organization's missions. AIMED Alliance is a nonprofit that seeks to protect and enhance the rights of healthcare consumers and providers.
And the Dermacare Access Network, or DCAN as we call it, is a nonprofit health advocacy coalition made up of a variety of dermatology stakeholders that are all focused on protecting patient access to approved therapies for skin conditions and appropriate clinical care.
Just to give a quick preview of today's slides, we're going to start off with Dr. Friedman, who's going to present on the impact of dermatological conditions in the workplace. Then I will present on access to treatment, the legal landscape, and recommendations. Chris will provide an overview of employee wellness programs. And then Catherine will provide the value of worksite health and well-being, and we'll end with a Q&A. So with that said, let's get started. Dr. Friedman, take it away.
Great. Thank you so much. And everyone, thank you for joining us. This is such an important topic. Because I think, we use the term more than skin deep so often, but this is such a reality that skin disease, while appearing superficial, very often has tremendous systemic implications that then spread well beyond the individual into the family life, into the workplace, and that's really what we're going to focus on today. So the slide you're seeing here I'm using because I think, I'll relay a personal story. Whenever I'm in a social situation and it comes out I'm a dermatologist, the first thing that happens is people start pointing to their face, they'll point to their jowls, and they'll start talking about Botox and fillers. And then, of course, I have to disappoint them and say, no, I'm a complex medical dermatologist, which is so less interesting to them, unfortunately. But very often the public perception of dermatology is just our cosmetic arm, which is hugely important. And, cosmetics do play a big role in how people feel about themselves and give confidence. But certainly there's so much more to dermatology, especially as we think about disease states that can tremendously impact quality of life. And then, of course, relevant to today's talk, the kind of impact on the workplace. Next slide. So the next slide really shows kind of more of a representation. Forward. The next slide is more representation of what I see on a daily basis. This is a patient with psoriasis, and this patient is covered with these thick, scaly, red, itchy plaques all over. And while psoriasis is a very common disease, it very often presents atypically. And depending on age, gender, skin type, location, it can look very protean, very different. But the unifying feature is that it is always disabling and always has a tremendous impact on quality of life. Next slide. Now, while psoriasis is a very common thing that we see from an inflammatory standpoint, dermatology is extraordinarily vast with respect to pathology. We see diseases of errors of metabolism, inherited diseases, malignancy, diseases of malnutrition. The list kind of goes on. And these photos really don't do justice to the broad variety of cases we see. Once again, a unifying feature here is that all these can be extraordinarily disabling and limit someone's full potential, of course, with respect to this talk, in the workplace. Next slide, please. So recently, this really lovely study was published in the Journal of American Academy of Dermatology, which is the leading clinical journal in dermatology, where this massive group of dermatologists got together and evaluated the quote-unquote burden of skin disease. And this was data they pulled from 2013. Like any of these epidemiologic studies, when the paper's published, it's usually based on data from several years before, because you obviously have to have access to that data. And they found some very startling facts, and we'll kind of go through some of those. Next slide. So I guess the first question is, well, how much of a burden is it? Well, they found that more skin disease claims were made across the U.S. in 2010 than cardiovascular disease, diabetes, and end-stage renal diseases. Three major medical categories or disease states that we all know have a tremendous impact on quality of life and social life, workplace life. So more skin disease claims were made than all three of these together. Greater than 26% of Americans sought treatment for at least one skin disease, but in fact, especially looking at our older population, about 50% of Americans greater than 65 had an average of 2.2 skin diseases each. So you think about the elderly population, and still I'd say actually nowadays 65 isn't even so old. It's now, 65 is today's 45. People are working much later in life, and certainly innumerable skin diseases can limit that productivity. Next slide, please. Now, I think the cost is of most concern, and we know healthcare costs can be exorbitant. And I think, in thinking about skin disease, it's definitely at the top. So in looking at this data from 2013, 85 million Americans were seen by a physician, now not necessarily a dermatologist, but by a physician for at least one skin disease, and that's about a quarter of the population. But these numbers are staggering. This resulted in direct healthcare costs of $75 billion, but indirect lost opportunity costs of about $11 billion. And that includes missing work, missing, various opportunities that really are intangible. Direct costs you can easily write down and kind of create a line item budget, but there's $11 billion worth of missed opportunities that you really can't quantify completely. Next slide. Any moment now. There we go. Impact of patients is substantial. I mean, that should be obvious at this point. Patients with skin diseases and their caregivers experience that $11 billion worth of lost productivity. And I think it's important to bring up caregivers. I'd also even include the family in there. No person is their own island. Chronic diseases, and especially skin diseases, don't just affect the individual. It affects everyone in that kind of localized community. And we'll talk about some disease states that are really relevant to that statement. I found also interesting from this study was the amount of money spent on over-the-counter skincare treatments. I think that's somewhat unique to dermatology, that yes, of course, prescription medications are involved in every facet of medicine and surgery, but there's this massive marketplace of over-the-counter cure-alls. Very often they can be misleading given the kind of limitations of FDA oversight with respect to claims of these products. And so people look to a quick fix when it comes to skin disease. And so there's also a missed opportunity to limit that cost expenditure as well. Another thing I found interesting is that about 25% of these individuals were about 0 to 17. So we're talking about a younger age. I was focusing on an elderly. I was focusing on, adulthood. We're also thinking about teenagers, and certainly teenagers, they're part of the workforce as well, entering to college, and that's where they're headed. A good number of these individuals are afflicted with skin disease that can affect, of course, their development and ultimate impact on the workforce. Next slide. Sorry for this little bit of a lag with the slide transition.
Yeah, I think there might be a little bit of a technical difficulty, but you guys should see it now.
There we go. As you're saying. So this is the table from that study that was, as I mentioned, it was published in 2017, but this data was from 2013. And you look across, the x-axis, numerous skin diseases ranging from non-cancerous growths, infections, fungal diseases, hair and nail disorders. The numbers start to go down. Certainly, 7% prevalence is pretty high when you're thinking about the general U.S. population. But the next slide, I think, is even more telling because just because you think about prevalence, that doesn't necessarily equate to an equivalent cost measure or even an impact on quality of life. And I think this is a great demonstration of that, where we saw those numbers of just prevalence, but the cost of managing these conditions is astronomically higher than the actual prevalence itself. So I think it's important to consider, just because maybe a disease state isn't as common as something like diabetes or high blood pressure, the cost of managing that chronic condition can be much higher than the overall prevalence. I think that this figure really highlights that point. Next slide. So I think psoriasis has somewhat become the poster child of chronic inflammatory disease of the skin that are much, much more than skin deep. This is a disease of chronic inflammation everywhere, not just the skin. Now, we see the skin, but there has been decades of work showing that undertreatment or no treatment at all and allowing this disease to progress can lead to innumerable comorbidities, other medical problems that can be quite disabling and, of course, cost lots and lots and lots of money. I think psoriasis was kind of the first chronic inflammatory disease that really got the attention it deserved in this arena. Now we're seeing the emergence of a lot of comorbidity data associated with other inflammatory diseases, some of which I'll speak about. So psoriasis roughly affects about 7.5 million persons. We always have to say about the population of New York City. And anywhere from 30 to 40% of these individuals will also get psoriatic arthritis, or PSA. I think that's a very important point, and I'll talk about that in a moment. We could see it in kids. A lot of kids can certainly get it. It generally manifests a little later in life. We often talk about this kind of bimodal presentation of maybe early 20s and then mid 50s, but somewhere, on average about by age of 35, that's typically when it presents. Of these numbers, about 20% have moderate to severe disease, where it can be extensive broad body surface areas, or even that severity can relate to it being localized to kind of cosmetically or socially sensitive areas like the scalp, under the breast, in the groin. And so while not a huge body surface area, the impact on quality of life can be bigger than if someone had it all over their body. And we're starting to recognize that it's not just about how much is all over your body in terms of how it affects you. No question, there's tons of data showing that it impacts quality of life in a very negative way, productivity, daily functions, your ADLs. And we know there are a lot of risk factors that go along with psoriasis. Psoriasis itself being an independent risk factor for smoking, obesity, illicit drug use, depression, the list kind of goes on and on. Next slide. So this is kind of just a way of looking at psoriasis compared to other common disease states. And this is just a measure of, how well someone is functioning from a physical versus mental rank. And you can see that psoriasis is unfortunately the winner here, in the sense that it is more disabling, both physically and mentally, than many of the common medical conditions we talk about on a daily basis. Next slide. Now, psoriatic arthritis, I think the skin disease here is certainly impactful. Psoriatic arthritis, especially if untreated, can truly be disabling physically, mentally, emotionally. It is often missed. Early signs of disease, and this is even by dermatologists, are not classic for what you think of arthritis. It's more stiffness with rest rather than pain with motion. But a good number of these patients with skin disease will develop psoriatic arthritis, and a good percent of those, over 20%, will have moderate to severe disease that isn't even treated. And so if you do not treat this, we know that it actually will get worse very quickly. Next slide. Any moment now.
Sorry about that.
That's okay. This is just, we're going to spend a second on this just to highlight that it's not just about the physical pain of this condition, but psoriatic arthritis, given its chronic inflammation, it can certainly have generalized impact. We know these patients have greater fatigue, decreased functional capacity, discomfort, sleep disturbance, all things you do not want for someone who you want to be productive in the workplace. So that's just the key message here, is that this affects every facet of life and therefore will affect the workplace productivity. And here, this is a very important slide from a really great study where they looked at patients who were identified within 6 months of onset and then treated, and then patients who were then missed for 6 months and then treated. And they found that the likelihood of more severe disease and resistance to treatment was actually much higher if you miss the diagnosis. So that's why it's so important that someone is eliciting signs early. They need to get in and get treated as soon as possible, or the impact could be quite sustained and unfortunately not reversible. So getting someone in early, especially someone in the workplace, we want to limit that damage. So the three disease states we're quickly going to talk about are atopic derm, hand dermatitis, and hyperhidrosis. Next slide. So if you think psoriasis is common, atopic dermatitis has its beat. About 17.8 million adults in the U.S. Forgetting in kids, we're talking about 20% of the population with kids. Very often starts early in life, but it can start in adulthood. Costs are astronomical. Definitely hits all the markers that we saw with psoriasis, and probably even more than that in terms of medical quality of life. Next slide. We know that it affects sleep. There have been numerous studies looking at patients, adult patients with atopic dermatitis, 3 times the rate of insomnia compared to the general population, 2.4 times rates of fatigue, which leads to workplace accidents. This has been recorded. Next slide. So quality of life, I'm not going to belabor this. This results in an impact on every facet of quality of life, and how that translates to the workplace. missed days, and we're talking about not just one, but multiple days due to this condition. And then even when they are at work, limiting that productivity because of a whole host of factors. Next slide. Hand dermatitis, so we're kind of focusing that this is a type of eczema more focused to the hands, most common occupational dermatitis. So depending on the workplace environment, the workplace could actually contribute to this disease. And it's extremely common, chronic, very, very disabling. Next slide. A lot of data in terms of its impact on work productivity. This is just from one particular study, functional impairment, overall impairment of daily activity. Next slide, which will show also lots of missed days of work, as opposed to even atopic dermatitis. 20% of individuals with chronic hand dermatitis, greater than 6-7 days of sick leave per year. I mean, that's a lot of missed work, which means lost productivity. And also, a lot of individuals will leave their job if they can't really get under control because they associate the quality of that condition with the workplace as well. Next slide. Someone didn't pay their Verizon bill here. Just kidding. I believe the next slide we're heading into hopefully hyperhidrosis. Yes, hyperhidrosis. So this is excessive sweating, 4 times the amount that's needed to actually regulate body temperature. Extremely common. Our initial numbers were about that of psoriasis. Could you hit forward because we have a pop-up in here. More recent data has shown that actually the prevalence of hyperhidrosis is much higher than that of psoriasis. Actually affects about 365 million people worldwide. It can start early in life. There is a known family history associated. It can be genetic, but we're seeing this affect people in the prime years of work life. Next slide. Great. So this is a study looking at impact on quality of life. DLQI is a kind of mechanism for looking at impact of quality of life. And they found that hyperhidrosis of the palms and underarms, the impact was greater than some of the diseases I already mentioned in terms of eczema, psoriasis, contact dermatitis. So this is an extremely disabling disease, which very often people don't even recognize it as a disease, which is part of the problem. Next slide. So, I mean, the impact is clear. So excessive sweating that has nothing to do with temperature, stress, whatever you're doing. There are extraordinary social implications. I would say in the workplace even more so, because I think we can all relate to appreciating that if someone is in the middle of a presentation or having a conversation at work and sweating excessively, it's obvious on clothing, which we know these patients often change their clothing throughout the day. The concern of how that's translated by the other people in the room or the other person as an added level of stress than even many of the other common skin diseases. It is under-recognized, underdiagnosed, and undertreated, probably more so than even some of the other diseases I mentioned. This was a recent study published, and we'll jump to the next slide, which has really the core data. So this is a survey of close to 2,000 sufferers of hyperhidrosis. And what they found was that in terms of level of satisfaction with respect to the treatment, antiperspirants, both over-the-counter and prescription, were probably recognized as the least effective and patients were least satisfied. However, in this study, they found that these were the treatments most often used by healthcare providers. So there's a big disconnect in terms of what these patients are getting and what actually works. And so I think we have a unique opportunity to get these patients in to get the right treatment and get to the right doctors. I'm going to finish up with this title of a editorial from one of the derm lay journals called Practical Dermatology, where there's this growing concern that, even with, emerging innovation in research and development and new drugs, the best drug for the patient is one you actually can get nowadays. And that is not the right message we should be sending. We should be able to get patients the right drugs that not only help them right here and now, but can actually prevent that progression I mentioned earlier, prevent the progression of psoriatic arthritis, prevent the progression of psoriasis, both from a biological standpoint, but also from a social and workplace standpoint, and that we prevent its impact on someone's career development and their ability to produce and really impact the overall workforce in the United States. And I believe that is the end of of my portion. And this was a quote from that article that really highlights the misery of prescribing nowadays. And that I will turn it over for the next part.
Wonderful. Well, thank you. That was very informative. We're now going to switch over to the access discussion. And to discuss that, just to reiterate some of the things that Dr. Friedman mentioned, there is quite a large direct cost with dermatological conditions, but then also in the workplace, you can see increased absenteeism, loss of productivity, and barriers to employment. In the converse, if patients that receive appropriate care and treatment, healthcare utilization can go down, you have improved productivity and decreased absenteeism. So what can employers do? Well, they can create welcoming environments for their employees, and they can choose their health plans carefully and provide adequate coverage and benefits. Just to go over some of the types of treatments that somebody with a dermatological condition may need, this is a short list. There are quite a few more, but you can see that access really is vital. And yet we're seeing that a lot of patients and employees have difficulty accessing their treatment. So this is just a recent headline showing that people with rosacea are turning to a medication made for horses to treat their condition because they can't afford their medication. So very inappropriate type of treatment. We're going to skip the poll, but there are specific types of benefit utilization policies that are aimed to reduce costs, and though they are cost effective and may be appropriate in some instances, if they're applied in an overly burdensome manner, they really can restrict access. So one of those is step therapy, and this is a policy in which an insurer will require a patient to fail on a less costly treatment before they can access the treatment that was prescribed to them. It can be inconsistent with standards of care, it can delay effective care, and it can cause unnecessary patient suffering. During that interim where they're waiting for their prescribed medication, if the initial treatment is not effective, their disease can progress, or they could relapse. And they may be required to fail on the same medication more than once if they switch plans. This is a recent article about an individual, a young boy. When he was 12, he was diagnosed with psoriatic arthritis. He first experienced it with pain in his jaw. He was prescribed a biologics, and his insurer required him to fail on a different medication first, which made him vomit, and it weakened his immune system. It was several months before he could access the medication he needed, and during that time, he had pneumonia and back-to-back episodes of strep throat that could have been avoided. Another type of policy is prior authorization, and this is when the insurer will not provide coverage of a treatment prescribed until the insurer approves of it. So it's basically the insurer second-guessing the doctor's medical determination. This also can cause delays and administrative burden because prior approval requires very specific forms. There may be a different form for every single medication. Sometimes it requires outmoded means of communication, such as fax and snail mail, which is ripe for the opportunity for these requests to get lost. And it can delay the process while the insurer is taking time to consider whether to approve the medication or not. Sometimes these decisions are inconsistent with medical standards of care. So we just heard about hyperhidrosis and how it is a medical condition, but many insurers will deny access to treatment because they see it as cosmetic. This is just a sample formulary of one health plan. As you can see, for acne, every single medication requires prior authorization. For some, there are age restrictions. For some, there's step therapy and prior authorization requirements. And you can also see those numbers refer to tiers. So on top of prior authorization step therapy, there may be increased cost sharing depending on what tier the medication is on. Next issue is non-medical switching. So this is a cost-driven change made to the formulary after the plan year has already begun. Typically, it's in the form of dropping the medication from the formulary altogether, or the medication could be moved to a higher tier with increased cost sharing. Whatever happens, the medication becomes unaffordable for the patient, and they can no longer take it because they can't afford it. So it's essentially a bait and switch. It forces stable patients to switch to a different medication. This occurs frequently with both biologics and biosimilars used to treat dermatological conditions, and it can have a negative physical impact on the patient, causing side effects and increasing healthcare utilization by the patient seeing their doctor more often or even going to the ER. The next type of policy is a copayment accumulator. This one is fairly new. Oftentimes, when a medication is placed on a higher tier in the formulary, the patient may need copay assistance. So they may seek that in the form of a coupon from a drug manufacturer or from a patient assistance program. However, with copay accumulators, these programs prohibit that assistance from counting towards the patient's deductible or the maximum out-of-pocket limit. So when you think about a coupon, typically if you go to the store, you give a coupon for milk, you get $1 off of that product. You can think of this in this way as you give that coupon to the cashier and then the grocery store gets to keep that value. It's not the way coupons normally work. It's essentially a double dip because the insurer receives the full value of the coupon from the patient, but then also requires the patient to spend down the entire deductible as well. And oftentimes, the policy is intended to steer patients towards lower cost or genetic medications. However, a lot of these medications don't have genetic alternatives. So there was a study showing that 50% of medications for which copay assistance is available don't have a generic substitute, or all they have is a similarly priced brand therapeutic equivalent. So copay accumulators can include very confusing language. Sometimes they use language that conveys a benefit rather than it being something negative to the patient. And also, it can be discriminatory. So this is a sample text from a large employer, Fortune 100 company. And you can see not only is the language confusing, but it only applies to very specific health conditions, including oncology. So that would be skin cancer, melanoma, and psoriasis, another type of skin condition. Copay accumulators tend to be more problematic for patients who are in high deductible health plans. As assistance runs out and their medication becomes unaffordable, they could be required to pay $3,000, $4,000 for one medication 1 month at the pharmacy counter. Especially if they're unaware of this, it can come as a shock and they may not have planned for that. So it may result in a lack of adherence because they may be rationing out their medication, they may need to switch, or they may just abruptly stop treatment altogether. And we are seeing widespread adoption of these policies, especially among large employers. So according to a study that was done in 2018, at that point, 17% of employers had adopted copay accumulators and 56% expressed interest in adopting in either 2019 or 2020. So there are some legal protections available. Some of these federal legal protections include the Affordable Care Act non-discrimination provision. So if any of these policies seem to apply more towards one health condition than others, especially with that copay accumulator policy we just looked at, that could violate the non-discrimination provision. Additionally, the FTC Act has a provision that prohibits unfair and deceptive acts or practices. So that could include non-medical switching, where the plan knew that it was intending on making a change prior to the beginning of the plan year, and then that January 1 date rolls around and all of a sudden the medication's not available. The patient didn't have notice. The patient may have done a lot of research to select the health plan to make sure it covered their medication. That could be considered unfair or deceptive. Additionally, if you have a plan that requires somebody to try and fail on the same medication more than once, that too could be considered unfair. Some of these plans may lack transparency or notice. We see that with the copay accumulator policies, in which some plans don't disclose their existence at all. ERISA has similar protections regarding disclosure, and it also has a requirement not to breach the duty to mislead, or the duty not to mislead. We have a lot more detail on these legal protections in some of our papers. And these two papers that are mentioned on this slide are available in the handouts for this webinar. There are also state protections. I do want to note that ERISA does preempt a lot of the state protections in employer-sponsored plans. But if you are offering a plan through a small business exchange, then these protections may apply. So that includes State Unfair Deceptive Trade Practice Act, very similar to that FTC Act. Also could be a breach of fiduciary duty if you change that plan in the middle of the year, or if you revoke a prior authorization after it's already been granted. However, a lot of these plans do have text that does allow them to make that unilateral change. So in that case, it could be considered a breach of the duty of good faith and fair dealing, because that duty acknowledges that insurers do have more of a bargaining power than consumers who enter into a health plan. And so that insurers do have a duty to act in good faith. Additionally, states are enacting their own laws and introducing legislation that specifically deals with these policies. So with step therapy and prior authorization, these laws tend to streamline the process. And with non-medical switching, it tends to prohibit plans from making mid-year formulary changes, or at least requires that patients who are stable on their medications can continue on those medications. With copay accumulators, the legislation would require plans to count that copay assistance towards that deductible and out-of-pocket max. We do have some recommendations for employers when you're selecting your benefits. We recommend that you select plans that are not overly restricted and that offer protections for employees with complex and chronic conditions. So just like we see with those state laws, you should voluntarily try and implement some of those same things, like streamlining prior authorization and ensuring step therapy and prior authorization standards are consistent with the standards of care. Some of those streamlines include offering uniform forms or having tight deadlines for the insurer to respond, things like that. Additionally, it's very important to offer several plan options so that the employee can select one that meets his or her needs. So, possibly one that has a traditional deductible, and then also some that may have high deductible, so they can choose what's appropriate for them. And then improve transparency. So make sure those plan terms are readily available in plain language and multiple language. And then you can also make stipulations through the contracting process. So you can say you don't want a copay accumulator policy or any mid-year formulary changes, and you can track and enforce those contractual provisions through performance guarantees. Additionally, you can offer plans with open formularies that don't drop medications, and you can also offer value-based dermatological programs. So Scripps does this with migraine, and it's a program that encourages treatment adherence to the medication. And if the treatment doesn't work, then the insurer or PBM, and ultimately the employer, gets a refund from the drug manufacturer. However, it is important to note that value should really be based on a patient-defined terms. And then finally, the appeals process. So appeals and exemptions are allowed when an insurer denies access to care. And this process should be streamlined so that stable patients can remain on their medication during appeals, that it's simplified, similar with the prior authorization, that the forms are uniform, that there are tight deadlines, that they're tracked, that they're accepted electronically. And then also employers can provide assistance with that appeals process. We have a website called coveragerights.org, and it explains information based on each state how you can appeal an adverse benefit determination, everything from that informal communication with the insurer all the way up to filing a complaint with an insurance commissioner or attorney general. So that resource is available to you. So with that, I'm going to turn it over to Chris.
Great. Thanks, Stacy. And Mike, thanks so much for including myself and Catherine. We're excited to talk to the folks as we switch gears a little bit here and speak to wellness. I've got 8 to 10 slides that we'll cover. And so really I'm going to start at sort of the 40,000-foot level and talk a little bit about wellness as a benefit consultant, some of the things that we do both here in the Northeast and across the country. It it's important to really know that, we continue to hear about wellness, but we all know that it can mean different things to different folks, from the employee and the subscriber right on down to the human resource folks, as well as the insurance carrier, which Catherine will speak to. It's important to note that many carriers offer basic wellness programs and tools, and some of those services are baked into the basic programs that you might purchase, and you can also supplement them with some additional out-of-pocket dollars. I give an example here. Here in Massachusetts, Blue Cross actually has a pretty unique approach to their wellness initiative. So they will provide up to $300 per year to employees who participate in the wellness program. And it's a simple process. It's a matter of doing your preventative screenings, get your biometrics taken care of, and then based on the number of folks that participate, the employer can receive up to 7.5% of the gross premiums returned at the end of the year. So it can be a pretty substantial subsidy kickback to the employer. Larger plans, especially on the self-insured side, but even on the fully insured side, as you get north of 100 employees, you'll see the insurance carriers will cede $25,000 or more annually towards wellness initiatives. Everybody having aligned interest to hopefully encourage folks to make good decisions and have healthy behaviors that will ultimately impact the plan's claims experience year to year. But I will say for plans that are less than 100 employees, typically it's a leap of faith, because a lot of times, for the most part, those plans are not claims driven. So as much as we encourage folks to make good, healthy decisions, that in and of itself won't necessarily drive the claims picture from year to year. Larger employers clearly, though, can have an impact. Just a few facts about wellness, and again, we hear the term all the time, but it's important to really get a feel for the impact. Some key facts here: 1.8 trillion is the annual impact of poor health. 75 billion per year in healthcare costs from smokers in the U.S. 2 times more loss to productivity per week. And the employees, we know that they need your help, and so 80% of Americans work in jobs that require little or no physical activity. So creating a wellness plan is not that difficult. It's not complex. It's not costly by any stretch, and you can create events to keep it fun, to get people up, to get them moving. 78% of Americans describe stress as a key component. But most importantly here, for every dollar spent on healthcare, 95 cents is spent on the treatment and only 5 cents spent on the prevention, which is staggering, really. So it's important to encourage folks to use the preventative services within their medical plan. There's no cost, there's no copays. As we know nowadays, all the preventative services are covered at 100% on your medical plans. Wellness programs can deliver many benefits. So costs fall by about $3.27 for every dollar spent. So the ROI on that is significant. 28% reduced sick leave, reduction in medical costs, significant. Absenteeism, significant reduction there. Okay, so and you can realize upwards of $264 per employee for on-site programs. 70% fewer sick days. So the domino effect can be considerable. Next slide, Stacy. Thanks. So what makes an effective program? And it's really important. You can't just say, hey, we got wellness. There must be a buy-in really from the top down, and it needs to have a consistent communication confirming as much. Employees, the rank and file, need to know that this is a legit program. It's got teeth to it, and you're serious about it, that you're not just rolling it out one year because it's the popular thing to do. We encourage a wellness committee, and it doesn't have to be a big group, and it doesn't have to meet once a week, but it's important to have that committee, and it should represent a good cross-section of each company. And you can create a 3 to 5 year strategy, but be willing to be flexible, adapt based on the company's culture, what you're trying to accomplish, and you can have a really meaningful impact. And so our approach really is the carrot or the stick. Many times we'll roll out a plan. There'll be a soft rollout. We call that the carrot. Hey, here's the program. This is what we're trying to accomplish. This is not going anywhere. We're behind it. And then second and third year down the line, you create more of a stick approach where if you don't do X, Y, and Z, your premiums are going to be that much greater. If you continue to do and make good behavioral decisions relative to your health, you can pay 20 to 30% less on your premiums, and perhaps we'll also drip money into your HSA account so you can get very creative with it. But money does talk. It's important. So a number of factors that are key when designing a program, and every group is different, of course. So your company demographics, culture, ultimate goals. What are you trying to accomplish other than just keeping your medical costs down? Want to make sure that your plan is compliant, and do you have the resources? Again, so it's not that expensive. Many of our clients we actually absorb as part of our structure. We provide the wellness program on a complimentary basis, and we have dedicated portals that help track the points. So we've got a couple of examples here that we're going to review, get down in the details, down in the weeds a little bit, but there's, again, different approaches that you can use. A simple points-based program, really, step one, annual physical with lab work, visit your PCP, and we track that for you. There's a program called Know Your Number Assessment, so it's just a 5-question online assessment to get an idea of what your own specific numbers relate to, and then from there we're going to collect those and track them. And so in this example, you could have a simple program that requires you to hit this 100-point threshold. You can determine the point structure, but when people do hit that 100-point threshold, the following plan year will have them realizing 15, 20, 25% reduction in premium relative to the non-wellness participants. Okay. Another variation of this program, option 2 here, a coaching program. So again, you can register your wellness portal. Employees complete the assessment online. They do their annual preventative screenings as part of step 3, get their on-site biometric screenings. And again, we lean on the carriers. Many times the carriers have these resources. They're ready and willing to deploy them, and they'll come to your offices to do the biometric screenings. Step 4, complete the health education and coaching. So you can have the wellness vendor provide outbound calls to folks that have certain scores, certain numbers that are determined to be high risk. And so now they're reaching out, outbound calls. It's a very soft, non-invasive approach that allows folks to, get the coaching that they need. So you can design the structure, the points, and the credits however you like. And then the last option, Healthy Ranges program. So again, steps 1 and 2, similar to the step option 1 and 2 program. But then as you determine your healthy ranges, you can create additional activities, and your screening will be used to determine your healthy ranges. So if you do not meet 3 out of 5 ranges, you can create another bogey for somebody to have to complete a certain step. And again, you're just encouraging folks. You're trying to move the pendulum. We like to say that most groups are made up in 3 parts. You've got the top third of the employee population. They're going to work out. They're going to eat healthy every day of the week. You could have a wellness or no wellness. They're going to do that. Sometimes the bottom third, you can bring the workout, material right to them into their living room, and they're not going to make good, healthy decisions. So we tend to focus ultimately on that middle third. It's trying to move that pendulum and getting those folks to move the dial and create, good, healthy decision making. So just some final thoughts. We encourage you to keep it simple and fun, but require accountability. The plan should have some teeth to it. Again, money does speak relative to, premium contributions on their medical plan or additional dollars being dripped into an HRA or an HSA account based on good decision making. And lean on your brokers and consultants and your insurance carriers, because there's a tremendous amount of resources that are out there. And sometimes folks just don't know where to go, what to ask for. And many times these things can be deployed without any out-of-pocket costs on your end. And so some of the initiatives that we routinely provide for our clients, in particular, customized portals, design and adjust the plans year to year. We track the points, and we structure the program for the wellness and non-wellness health premium. So that's just a sort of a high-level overview, trying to provide some touch points for groups that are sort of under 100 employees versus over 100 employees, because there's different components that go into it. And that's it. Thanks so much. I'm going to turn it over to Catherine. She's going to spend some time talking about United Healthcare's approach to wellness.
Thank you, Chris. Good afternoon. So the next few minutes, I'm just going to talk about, why we do worksite wellness, the importance of measuring health ownership, and then some steps to ensure successful programming for you. So why wellness? We all know that our current healthcare situation is pretty much unsustainable right now, and that poor health impacts productivity in the workplace, but also in people's homes. We also know that 80% of all premature heart disease, stroke, and type 2 diabetes can be prevented if we all did, 3 simple things. If we ate healthier, exercised more, and stopped using tobacco. So our goal is we want to keep, the healthy, but we also want to help with the progression of chronic disease. 86% of healthcare costs are the result of treating chronic conditions right now. The chronic disease progression happens gradually over time, and population data demonstrates how conditions worsen year over year. So when we look at this pyramid, individuals often progress from being considered healthy to becoming at early risk, and all the way to developing chronic conditions such as diabetes with complications of heart disease, stroke, and even blindness. Next slide. So it's really important to drive health ownership, because when people are making better and more informed decisions around their own health, typically we're going to feel better, we're going to be more productive, and have an 8 to 15% lower medical cost. So we continuously at United Healthcare look at data around decision-making in 3 areas: clinical, financial, and resources. So clinical looks at things like, are they getting their preventive screenings? Are they getting their annual physicals? Financial, are they going to the appropriate care setting, using an in-network provider? Are they using generic medications whenever possible? And resources, are they utilizing all the tools and resources available that are out there for them, within their carrier to help build awareness and help people make informed decisions whenever possible? So through all of this, we have found that 44% of our book of business are making suboptimal decisions. Oops, sorry, can you just go back?
I'm sorry about that.
Oh, that's okay, sorry. So at the bottom right-hand corner, this is what we found, that 44% of our book of business are making suboptimal decisions around their health. But we also found that for every 1 point increase in the consumer activation index, or people's decision-making, we usually see a 0.25% medical cost savings. So now we ask, how can we help get people more engaged? Next slide, please. So this is an example of one of our clients' decision-making performance, or what we call internally the customer activation index. So right now, this is looking at more than 4,600 unique decisions by its members. And currently, this population is activated at 60.8%, which we see in the upper right-hand corner. And as mentioned earlier, for every 1% increase in activation or the decision-making, we often see a 0.25% medical cost savings. So in this case, if we look at some of the low percentages here, clinical prevention, resource participation, those are pretty low for this client. So we want to do campaigns in both those areas to get more people engaged, in clinical prevention, in their own health, and also educated to making the decisions with the resources available for them. Next slide, please. So this right here is, we were looking at an engagement analysis of one of our customers that has an incentive plan in place. Typically, what we find is more engaged population they're making better decisions around their health care and also costing less to the medical plan. So you can see the engaged employees here had lower ER utilization, overall better adherence, and they made better health care decisions. So when we look down the bottom, measure of ownership, and we just looked at the slide before, the consumer activation index. The engaged population here is 18.5% higher than the non-engaged. So this is what we want to see. This is, everything that we do around wellness, that we can come back and say, hey, what you're doing is making a difference. Your population is making better decisions around their health. And look at those preventive screenings down the bottom. They are significantly higher in all areas, cervical, colorectal, mammogram, for those engaged in their health. Next slide, please. Okay. Is it advancing?
Yeah, I think it's stuck, but you should see it.
Oh, okay, that's okay. Okay, so how do we go about this? How do we build a successful program? And Chris spoke a little bit about it already, but generally all wellness organizations support some form of the 7 steps for successful planning. So these include securing senior level support, and this right there is imperative for a wellness program. A great wellness program has its mission, vision, and budget as part of the overall business plan of the company. You want to establish a wellness infrastructure. So that means creating a committee and champions. They're going to help assist with the promotion of the programming and also help engage other employees into the program. Identify target areas. You want to make sure that it's designed to actually make a difference in the health and well-being of employees. And these areas can be identified in various ways, having an interest survey, a health survey, and looking at medical claims. Creating a strategic wellness plan. Together as a team, you want everyone involved in this and just be able to follow throughout the year. And preferably if you're able to look at, a 3-year plan, that's even better. Developing appropriate interventions. This is when you want to get everyone together, senior leadership, the committee, your insurance carrier, your consultant, and together determine appropriate interventions. Creating a supportive environment. Think of this as creating the culture of health for your organization. And this can be as simple as installing water stations to creating a gym or relaxation rooms. And lastly, evaluate the results. A successful program needs to be measured, and senior leadership is going to want to see those measurements also. So it's important to keep data on participation, behavioral change, and also looking at the consumer activation score. Next slide, please. I want to share what some of our highly engaged clients are doing around incentives. So as illustrated by this chart, the winners of our well-deserved award had specific core incentive plans that drove engagement into the wellness program. The most common incentive used by 81% was reducing or waiving health insurance premiums. Additionally, 18% provided funds into an HSA or an FSA. And then 54% also provided gift cards or incentive drawings throughout the year, and 45% of them also provided reimbursements for wellness activities such as a 5K or gym reimbursement. Next slide, please. So when you are ready, or if you already have, a wellness program in place, please keep these best practices in mind. Have a health and well-being program design and strategy. Design an incentive structure around it if possible. Make sure to have a robust communication strategy. That golden rule of communicating in 7 different ways. We all see and hear about things differently. Make sure to include a worksite alignment within your strategy. And lastly, remember to measure and evaluate all your interventions. Thank you.
Thank you, Kath. And great job, everyone. That was incredibly informative. Before we conclude, we'd like to take some questions that any of the attendees might have for any of our panelists or in general. So as a reminder, you can still submit questions on the portal through the questions pane on your attendee control portal. So Stacy, do we have any questions queued up?
We do. We have a couple. So the first one is, what types of things can employers do to create a welcoming environment for employees? So I could give some tips, and then I'll see if anybody else has tips as well. But one off the top of my head is to make sure that you are offering a place where people feel comfortable coming to you, especially if they have a health condition or maybe even need some sort of accommodation in the workplace, that they know that you're not going to judge them or cause stigma based on their condition, especially with skin conditions, and that they are comfortable asking for those accommodations and bringing up their condition. Does anybody else have any other tips on welcoming environment?
Casey, this is Chris. I would throw in one of the things that we use that's really successful is a program called Brain Shark, and it really among other things, it's an onboarding tool. So every new hire, or you can send it out to current hires to remind them. It's more of a branding for the company to have a message from the top on down, and we typically include different themes around wellness, around HR, and all the different resources that the company might have. So it's something that you can send out as a link and folks can see it, and there's a consistent theme and message communicated.
Mm-hmm. Yeah, great. We also have a question. What is the data supporting the notion that the healthcare system is unsustainable?
It's just the way things are trending, where we're trending with, where we're seeing diabetes going, where we're seeing obesity going. And when I say that, I mean it's the cost that it's costing employers, it's costing, Americans, it's, right there. We need to, start. I mean, I've been an oncology nurse for 25 years, so I've been on both sides, of the spectrum. And the days of, I've got high blood pressure, so I'm going to take a medication. I hear people say that. My mom had that. And so it's just that's how it is. And we kind of have to really change those trends and really look at, other ideas and out of the box of things to really be able to sustain healthcare, going forward for the next, years and years and years ahead of us.
Okay. And then one more question about wellness initiatives. How can we ensure that that big data collection from these wellness initiatives are not being used to ultimately deny coverage for premium, or ultimately deny coverage and could be used to charge higher premiums if ACA were repealed or deemed unconstitutional?
Yeah, that's a good question. So the vendors and any of the tracking tools that we use include a privacy agreement. So the employer signs off on that, and then we communicate as much to the subscribers so that the information is never shared and it's never dispersed out to the insurance carriers on any personal level. Any of the reporting is all in aggregate generic information.
Great. All right, it looks like those are all the questions that we have. We just want to thank all our speakers. Mike, did you want to?
Sure. Just before we close, we'd like to thank our corporate sponsors for today's educational programs, Sanofi and Leo Pharma. Thanks for your support. And once again, thank our illustrious group of speakers, Dr. Friedman, Chris Costello, and Catherine Theodore.
Yeah, wonderful. I do also want to mention that we have some handouts available in the handout section, and that there should be a survey following this presentation. We request your feedback. We also want to invite you to part 2 of this webinar, which will be April 26th. We'll be sending out information on that shortly. We're going to have an economist speaking and another attorney. And then we want to thank everybody on behalf of the speakers today. If you are an HR professional or benefit manager looking for SHRM credit, the course code is up here on the screen right now, and our contact information is available if you have any additional questions. With that, I just want to thank everyone again, and have a good afternoon.
Thanks a lot.
Thanks so much.